Good afternoon. Welcome to the Vancouver Bone Squad MSK lecture series. Today we have Sandy St Cyr from UBC Hospital giving today's lecture. We are recording on Zoom, and a recording link will be sent out later this evening, and you'll have 10 days to view the recording. Please remember to fill out the assessment form to get your CME credits, and you'll be issued a CME certificate at the beginning of January 2027.
Welcome everyone to another edition of the Vancouver Bone Squad lecture series. This week we have the pleasure of having the fabulous Sandy St Cyr. Sandy has been practicing as a sonographer with subspecialty into MSK sonography for 24 years and has been the lead and innovator of the BCIT course for sonographers for MSK radiology. She's also part of our faculty teaching tirelessly our MSK fellows here, and I've learned a lot from her over the years. I'm sure you will as well with this talk. So without further ado, Sandy St Cyr on sonography of the dorsum of the wrist and distal forearm. Sandy?
Thank you. Thanks very much for inviting me, Hugh.
Pleasure.
Hopefully you won't be sorry. This is me, hard at work, scanning the dorsal wrist. My email for work is attached there, just in case you want to send me any messages. Why I chose this topic? Well, it's a common exam. Superficial structures, we can use high-resolution probes, but it's a really complex, busy place, so you really have to know what you're looking at. Plus, I asked Karen what people requested, and it was on the list at the time, so I figure it's a win-win. I'm going to talk about the anatomy, the sonographic anatomy of the dorsal wrist and forearm, and in a bit of detail, I'm going to include the extensor muscles, tendons, and all the bony landmarks. I'm going to talk about an approach to a study of the dorsal wrist, mostly based on the worksheet that we use, and I'll share some common pathologies. In the anatomical position, the bones of the upper limb include the humerus, and there's a medial and a lateral epicondyle, which are the palpable bony landmarks. Long bones in the forearm are the radius and the ulna, carpal bones at the wrist, and then long bones again, the metacarpal bones and the phalanges, and these are all numbered 1 to 5 from radius to ulna. The bony wrist is composed of the distal end of the radius and ulna and 8 carpal bones. There are palpable bony landmarks you want to think about on the ulnar side, the ulnar styloid process, and the radial styloid process on the radial aspect. And then the most important palpable landmark is the dorsal radial tubercle, also known as Lister's tubercle, which is slightly radial from the mid-sagittal. There are 8 carpal bones, as I mentioned. If you need a mnemonic to remember them, you can use this one, Sally left the party to take Kathy home. If you take the first letter of each word starting in the carpal bones on the proximal row, S for scaphoid, L for lunate, T for triquetrum, and the pisiform is going to be on the volar side. So you won't see it when you're scanning the dorsal wrist. And then in the distal row, T for trapezium, T for trapezoid, C for capitate, and H for hamate. There are 2 rows of carpal bones, the proximal row and the distal row. And the distal radius articulates with the scaphoid and the lunate bones. The ulna does not articulate with the carpal bones because the TFCC, the triangular fibrocartilage complex, is in that location. And I'm not going to talk about the TFCC because I don't think I can really assess it well with ultrasound. I'm going to leave that to MRI. We look at a number of joints, synovial recesses in the dorsal wrist. Most commonly, we look at the radiocarpal joint, the midcarpal joint, and the distal radioulnar joint, or the drudge. Normally, they don't communicate. They're only going to communicate if there is a tear in the capsule or the ligaments. Other joints that should be on your radar would be the STT joint or the triscaphe joint, which is the joint between the trapezium, the trapezoid, and the scaphoid. It's a common area of OA, and it's deep to compartment 1 at the radial wrist. So it may be the source of the pain. Patient may be presenting with extensor compartment 1 for assessment, and it may be just because it's the joint. This is going to communicate with the mid-carpal joint. The other joint that you need to be on your radar is the first CMC joint, or the first carpal metacarpal joint, which is between the base of the thumb and the trapezium. It is extremely common to see osteoarthritis in this location. Again, deep to compartment 1. The other joints would be the CMC joints 2 to 5. Those are all considered one joint. They're between the bases of the metacarpals, the 2nd to the 5th, and the distal carpal row. The 2 dorsal wrist ligaments that we look at with ultrasound would be the dorsal scapholunate ligament, which is intrinsic. It's between the scaphoid and the lunate, and the dorsal radiotriquetral or radiocarpal ligament, which is extrinsic between the radius and the triquetral bone. I'm going to move on to the extensors of the carpus. The muscles are located in the superficial layer of the posterior compartment of the forearm. They include extensor carpi radialis longus, or ECRL. Just a heads up, I'm going to be using the acronyms moving forward. The origin is at the supracondylar ridge of the humerus, insertion on the base of the 2nd metacarpal. Extensor carpi radialis brevis, or ECRB, origin at the common extensor origin on the lateral epicondyle of the humerus, and insertion on the base of the 3rd metacarpal. Extensor carpi ulnaris on the ulnar side, again, origin at the common extensor origin, insertion on the base of the 5th metacarpal. So just remember, the extensors of the carpus all insert on a metacarpal. Moving on to the extensors of the digits, most of these muscles are located in the superficial layer of the posterior compartment. They would include EDC, or extensor digitorum communis, which is unique because it has 1 muscle and 3 or 4 distal tendon slips. I say 3 or 4 because sometimes the slip for the 5th finger is absent. You can see them distally there, and then you can see the slip that goes down over to the 5th finger right here, and it's going to join with EDM at the MCP joint. Extensor digiti minimi, or EDM, origin is at the CEO, and insertion will be at the base of the distal phalanx. Extensor indicis moves the index finger. Its muscle is located in the deep layer of the posterior compartment. You can see all of these tendons if you extend the fingers. 2, 3, and 4. You can see the slip for the 5th, and then EDM. The muscles and tendons that move the thumb are located in the deep layer of the posterior compartment. These all have the word pollicis included in their name. Abductor pollicis longus, origin here. Insertion on the base of the 1st metacarpal. Extensor pollicis brevis, or EPB, origin is here. Insertion is on the base of the proximal phalanx, more dorsal. And extensor pollicis longus, or EPL, origin here. An insertion on the base of the distal phalanx, again, more dorsal. EPL is the longest, most distal insertion. And just note its trajectory. Movements of the thumb, just to review, this is thumb extension. EPB is the primary tendon that moves that MCP joint. EPL is just going to assist. And for the IP joint, EPL is the tendon that moves it. Thumb abduction looks like this. Abduction at the CMC joint is performed by the abductor pollicis longus, or APL. As the tendons travel over the dorsal wrist, they are enclosed in synovial sheaths, which are blue in this diagram, and they're just meant to reduce friction to the extensor tendons. And there's also an extensor retinaculum, which is kind of like a tensor bandage wrapping around that dorsal wrist. It's a focal thickening of the deep fascia, and its function is essentially to hold those tendons in place and prevent bowstringing during movement. There are some vertical fibrous septa that dive deep from the extensor retinaculum, and they attach onto little bumps on the bone, and they form tunnels or compartments for the extensor tendons, and they are numbered from 1 to 6 from radial to ulnar, and I'm going to describe them all later. An anatomical snuff box is located on the radial aspect of the wrist, and you're going to see it if you extend the thumb. It's triangular. You can see it right here, and it's formed by the tendons of EPB, EPL, and APL, which is more volar. There are 2 intersections. The proximal one Compartment 1 crosses over compartment 2. At this level, there are no sheets to protect, so we tend to see more pathology at this location. At the distal intersection, C3 crosses over C2, and at that location, there are sheets to protect. So I personally have not seen a case of distal intersection syndrome. I know it's out there, but I haven't seen one. Your tip here is compartment 2 is always going to be deep in both of those intersections. Now, there are also some nerves to think about. On the radial aspect, the superficial branch of the radial nerve has fascicles that travel down at that location, and they cross over the retinaculum and also compartment 1. You'll also see the radial artery at the radial wrist. And then on the ulnar side, there's a little nerve, and that is the dorsal cutaneous branch of the ulnar nerve. It comes from the volar side and travels dorsally and heads over to the dorsum of the hand. It crosses over compartment 6 or ECU. Now, I want you to remember that the thumb is a good reference. The thumb is radial. In the anatomical position, radial is lateral. Therefore, the thumb is always lateral. And the reason I point this out is because when you turn your hand from palm up to palm down, you pronate. The joint movement is at the elbow. The radius crosses over the ulna, and the ulna does not move. But because of this, the thumb can be located either on one side or the other, which can be very confusing. Because of this, we suggest that you annotate your images, radial and ulnar, as opposed to medial and lateral. Your big take home for today, maybe this is your most important one. It's a quote by my favorite mentor for our MSK Ultrasound, Dr. Luck Louie. In MSK Ultrasound, the bones are your friends. Long bones are easy to find, and you can turn in long on them and follow them to the joint next to them. Some bones have characteristic appearances, for example, the scaphoid, the trapezium, and the capitate. I want you to get acquainted, become friends, and they will help you find your way. This is an image of our skeleton in our department. I have named him Stan the man. He's been very helpful for teaching, and I thank him every day for his contribution to teaching. This is Stan's wrist and part of his hand. You can see a long bone here, the first metacarpal, another long bone, the radius. The trapezium at the base of the thumb on the volar radial side has a flat top, and the scaphoid is in the proximal row. Now, to me, the scaphoid looks like a cashew nut or a lounge chair, so it's easy for me to recognize. You can follow the first metacarpal and long axis to the first CMC joint. You'll see the trapezium, the flat top, then the scaphoid, and the STT joint, and then the radius. Just simply by following over the long bone. There's the CMC joint, there's the flat top trapezium, and the STT joint, and the scaphoid, and the radius. That's an easy way to find those joints. To me, the capitate has a saddle shape. Sometimes it's described as a bell shape. Bony landmarks you want to think about are the scaphoid, the lunate, the capitate, blisters, or the dorsal radial tubercle, the triquetral bone, the radius, the ulnar styloid, and the trapezium, especially for the first CMC joint. We can't really see the trapezoid very well with ultrasound. Probes you would use, well, I usually do a general survey with a large footprint probe. This is sort of my multi-purpose probe. I would reach for that highest frequency probe more often when I'm scanning the wrist because the structures are so superficial. I may need a probe with a slightly lower frequency, but if I need more penetration. And always, if I have one, I'm going to reach for that small footprint probe, especially for nerves and small structures. Often I use 3 probes when I'm doing any case. You want to have the hand and wrist pronated with slight volar flexion. You can easily use a folded up towel or the gel bottle. Always we have an extra gel bottle on hand. Also, that little bit of volar flexion can be useful when you're doing dynamic maneuvers. For the radial aspect, you want to rotate the wrist and have a bit of ulnar deviation. For the ulnar aspect, you want to rotate the wrist and have some radial deviation. You want to have lots of gel because it's easy to compress fluid in joints or tendon sheets because they are so superficial. Also, you can compress those tiny little vessels and dampen the flow. You want to have quite a viscous gel so that it doesn't run off and you can have kind of a gel standoff. Here's how not to hold the probe. Don't hold it like a club. Don't grip near the handle. You're going to have very poor control. Here's how I suggest you hold the probe. You want to anchor your fingers on the patient for good control, and you're going to use your first, second, and third fingers for those small movements. You can see on the left, there's poor control of the probe, and on the right, there's much better control. This is what you're aiming for, anchoring your fingers, having kind of like a tripod hold. That's really the best for probe stability. Some movements of the probe, I might use this terminology, so just to get you familiar, when I say translate, I mean you move the transducer to a new location while you maintain a perpendicular angle to the skin surface. Or you can sweep the probe. It's like sweeping a broom. You can sweep in any direction, back and forth, medial to lateral, proximal to distal. Anisotropy is going to either be your friend or your enemy, so you need to try to control that artifact. And the two ways to control it would be either to move the transducer, because you're aiming to have that inclination angle at 90 degrees to the structure you're looking at. So for example, you can heel and toe or toggle, or you can move the patient so that the structure is 90 degrees to the transducer. Heeling and towing, you can visualize that retinaculum much more clearly. This is going to help you obtain the best possible images. When you heel and toe the transducer, you rock or angle it along its long axis. The transducer does not move from its location, it is angled. It would be the heel of the probe, and this would be the toe. When you toggle the probe, you simply angle the transducer from front to back, similar to a toggle switch. These are just subtle movements that help you to make decisions. You can see how the bone gets bright and the tendons appear and disappear. Tendons, if they are ruptured, will stay echogenic, but tendons, if they are intact, will disappear. Our worksheet, Dr. Louis has come up with a very simple to use worksheet where we can just check boxes, and also we can refer to the structures that we're supposed to be looking at. There's an area for the patient's ID, there's an area for history, the different joints that we should be assessing, the tendons, and a diagram on the bottom that we use from Radiopedia, and then the ligaments that we assess. And then there's another little area for any extra findings we might have seen. You want to have your patient seated, preferably facing you. Then it's easy to compare the contralateral. You want to have them comfortable. You want to have a firm grip on the probe and have that wrist in partial flexion. Alternatively, if the patient is not able to sit, if they come on a stretcher, you can have them recumbent with their wrist by their side on a gel bottle or a rolled up towel. It can be on their tummy or on a bedside table. You want to have both wrists available for comparison. That's so important with musculoskeletal imaging. Really important to get a careful history. The requisition or the clinical question may not be enough. Always you want to look at prior imaging or documents, but talk to your patient. You can get so much more information, and that can lead you in the right direction. You're thinking about joint disease. Is it an overuse injury? You want them to localize the area of symptoms and what movements reproduce their pain. Is it related to tendon disorders, or is it just a lump or a bump where you're scanning? But sometimes lumps and bumps can be tricky. Another big take-home point, ask the patient to point with one finger. Dr. Louis taught me this. Don't let them do a big circle with their finger. They need to try and localize. Now, if they do this, or this, or this, you're probably thinking it's related to the joint. You can palpate with their permission, to see if maybe it's firm or tensile. This one's pulsatile. It's a bit of a worry. You always want to assess the joints first. You're looking for any signs of an inflammatory process. You're looking for fluid or thickened hyperemic synovium. We look at the radiocarpal joint. We can decide if it's normal or maybe there's something we want to tick off in the box. Distal radioulnar joint, same thing, looking for specific things. I just want to talk about the appearance of the dorsal radiocarpal joint in long axis at the radial aspect. To me, it has a characteristic step shape because the radius kind of drops off and the scaphoid does at that location. You can see the hyaline cartilage on the scaphoid. And to me, it always looks like a step. So that helps me to know what I'm looking at. And when you're in the mid-sagittal plane, the bones have a more rounded appearance. A lot of things you can see with that representative image in the mid-sagittal plane. You can see compartment 4 traversing over the joints. The retinaculum is always thick there, the extensor retinaculum. Often you see some normal vessels. And again, to me, the capitate is a saddle shape.
The dorsal radiocarpal joint, these are the recesses, and they tend to extend slightly past the joint lines. They have a redundant fold, and that just helps with increased range of motion for the wrist with flexion and extension. In long axis, from radial to ulnar, that's how I always start my assessment, starting with the joints, and you want to float the probe. You're looking at the cortical surfaces, you're looking for joint effusions, you're looking for thickened synovium, and you always will see a normal vessel unless it's a bit of a disaster, but you should see a normal vessel over the capitate. To the lunate now, and then more ulnar. Then I turn orthogonal and I'd sweep from proximal to distal, again, floating the probe, light pressure. You're going to follow the long bones, your friends, to the radiocarpal and midcarpal joints. You don't want to compress the veins because it's really easy to miss fluid. Coming off of the radius here, this is the proximal row, and then on to the distal row. So float the probe, really easy to miss fluid, a joint effusion, if you're pressing hard. When we're scanning, we tend to press hard because we get better images. So in this case, just back off, put a lot of gel, and look carefully just at the joint. This patient had a history of aching or throbbing pain at his dorsal wrist. Also, if you're assessing for hyperemia, float the probe. It's really easy not to see that vascularity. This is just an example, synovial hypertrophy and fluid in the joint with some sonopalpation. You can see the movement. Now I'm going to tell you how to find the distal radial ulnar joint. You're going to follow the radius and the ulna from proximal to distal, and you will see the interosseous membrane between the two bones. And you'll watch as the bones come together, and this is the distal radial ulnar joint. Best imaged in the axial plane. The EDM tendon, compartment 5, is a really useful landmark. It sits right on top of that joint capsule, and you can see quickly whether it's lifted off, and you'll get an idea whether there's something going on in that joint. You can confirm that's EDM if you do a dynamic maneuver. Sweep through that joint, make sure you haven't missed anything. And again, looking for the same things as you would in any joint. And maybe you're not sure, you can do a little bit of supination and pronation. And that's just going to push the capsule more dorsally. You might see some nitrogen bubbles down deep in the joint. Quick visual here, you can see clearly that compartment 5 is lifted off the ulna. You look to see why. It's thickened, it's solid, that's synovium. Also in this case, there's fluid in the distal radial ulnar joint, and again, you can see compartment 5 is lifted off the bone. This is gout. I couldn't even find the compartment 5 tendon. You just see these echogenic blocks of stuff with echogenic foci. I'll move on to the tendons. They are located in anatomical fiber osseous tunnels or compartments like I described earlier. Our worksheet, we use this diagram from Radiopedia. I flipped it so that is going to correlate with my images. From radial to ulnar, 1, 2, 3, 4, 5, and 6. Again, 1, 2, 3, 4, 5, and 6 approximately, if you're looking at your patient. The extensor tendons in compartments 1, 2, 3 are arranged in a long, short, long order. APL, EPB, ECRL, ECRB, EPL. Compartments 1 and 3 move the thumb. P for pollicis in their names. Pollicis means the thumb in Latin. Compartments 2 and 6 are extensors of the carpus. Compartment 4 is the largest compartment. It contains extensor indicis plus 3 or 4 EDC tendons. And it has the thickest retinaculum because it's the biggest compartment. And compartment 5 moves the 5th finger, and as I mentioned, it's a landmark for the dredge. So that dorsal radial tubercle, or Lister's tubercle, is a really important bony landmark, and I call it home. The tendon compartments that are radial to that tubercle are the 1st and 2nd, and the ones that are ulnar are the 3rd, 4th, 5th, and 6th. You can palpate Lister's tubercle, and it's slightly radial to the midline. And if you're lucky, you can put the probe on it and you can be right over top of the tubercle. Again, that's home. Or you can sweep over the radius and ulna until you see that bony prominence on the distal radius. Again, that's home. Lister's tubercle separates compartment 3 and compartment 2, and it's important to assess it really carefully for cortical irregularity because it may cause attritional tears of compartment 3, EPL. And in my illustration with my friendly skeleton, you can appreciate, if you have an imagination, that if there's an irregular cortical surface or if there's hardware, that tendon might tear. Lister's tubercle, a common appearance for all you surfers out there. For assessing these tendon compartments, short axis is the most useful approach. You're going to follow each tendon from proximal to distal, from the MTJ to the distal insertion, and always look in short and long. Use Doppler, float the probe, and many times you'll need to use dynamic maneuvers. So how to find the compartments? You're going to sweep to the Lister's tubercle, the dorsal tubercle, which you're going to call home. You're going to translate radial to compartment 2, and then compartment 1, depending on what you're trying to look at. You go back home to the dorsal tubercle, find it, and then translate ulnar to compartment 3, 4, 5, and then all the way ulnar to 6. So following the radius, finding Lister's tubercle, radial to compartment 2, and then all the way radial to compartment 1. It's further than you think. I recommend always going home and finding your way. Back to Lister's, there's compartment 3, there's compartment 4, 5, and then all the way ulnar over to compartment 6, ECU. Compartment 1, APL, EPB. APL is more volar, EPB is more dorsal. Things to think about. You want to think about that proximal intersection and a bony septum, which can be linked to subcompartmentalization of that compartment. Probe position is here. You'd have the transducer on the lateral aspect of the radial styloid. There's the tendon, and the retinaculum is that echopore structure over top. You always want to look at that retinaculum because that's where the pathology with compartment 1 begins. You're looking at the thickness, the echogenicity, the hyperemia. Is it where the patient has pain? Most commonly, it's going to be less than 0.5 millimeter. Easy to eyeball it. Take note of where that radial nerve, the superficial branch, is and the location of the radial artery. Especially if you're performing a procedure, nobody wants to skewer that nerve. It crosses over compartment 1 at the radial wrist, and you can see this tiny little fascicle here is one of the fascicles of that nerve. Nerves are mobile. You may feel a snap as you're scanning over compartment 1. Often that's the nerve. Remember also the cephalic vein is traveling with the nerve at that location. Easy to compress. Float your probe. Sometimes it's difficult to see 2 tendons at that radial wrist because they're being compressed, so I suggest you sweep. Remember, APL is more volar, it's larger, and it has multiple slips. That's often referred to as the lotus root sign because there's multiple terminal lamina and a single insertion. This is a potential pitfall. Do not mistake this for longitudinal split tears. Also, EPB most often is small compared to APL. So if you put that probe down and you see they're the same size and the patient has pain, you're going to have to look really carefully. Big tip here, when you're sweeping over compartment 1 from proximal to distal, there are some joints deep to your probe. That may be the source of the patient's pain. It may not be compartment 1 at all. So always look deep. Again, in long axis, these tendons are much easier to see at the distal insertion in long axis, but you want to remember there are joints deep in this location. The CMC joint, the first CMC joint, and the STT joint. Again, common areas for pain. Dynamic maneuver for compartment 1 would be done at the wrist, and you're watching to see if the tendon slides freely deep to the retinaculum. I mentioned that bony septum. Compartment 1 may be subcompartmentalized. It's an anatomic variation. If this is the case, the changes may affect only one of the tendons, and that's often EPB. You need to look for a prominent little bit of bone, an osseous or bony septum on the distal radius. Compartment 2, it's usually pretty uneventful, ECRL and ECRB. It's not common to see variants or accessory tendons. Sometimes it's bifid. Sometimes you see a small amount of fluid and the patient's asymptomatic, so nobody really cares. So you can see the two tendons, ECRL, ECRB. ECRL is more radial or more lateral. They are wrist extensors. They do not move the fingers. In short axis, they're really easy to see. Retinaculum over top. Proximal intersection here, C1 over C2. And then traveling more distal, you'll see EPL traveling over top of compartment 2. That's the distal intersection. So you can see lots of things when you're sweeping over these compartments. This is just turning in ECRB and long axis. Compartment 3, EPL, it's on the ulnar side of Lister's tubercle. It has an oblique course. It crosses over the C2 tendons, the distal intersection to reach the thumb, and it joins EPB at the base of the first metacarpal, and it gets a little bit tricky at that level to keep going. Again, longest thumb tendon. You need to look for all of these things again, like before, and also assess Lister's tubercle and also look at the distal intersection. This is where your probe would be. Toggle, especially if you're thinking about rupture of EPL and also you're assessing the dorsal tubercle. And this is a normal variant where you have 2 bumps on the dorsal tubercle. The distal intersection where compartment 3 crosses over compartment 2. And again, there are sheaths here, so it's not as common to see pathology at this location. You can follow EPL in an oblique transverse plane perpendicular to its long axis, cross the distal intersection, and turn orthogonal at the MCP joint. I find it's easier if I do that because it's so small, it's really easy to follow. So you're following it and it's crossed over the distal intersection, and you can see this tiny, tiny little tendon here. There was a little bit of fluid in the sheath. And as you're approaching the MCP joint, you'll see another tendon coming to join it. That's EPB. At that point, I turn in long axis and then try very carefully to follow it in long. It's really difficult because that tendon is so thin, and I'll follow it to its distal insertion. And then usually I have to do another image showing it dynamically at the joint. It's a really important area to assess, especially if the question is EPL rupture. You have these subtle probe movements. You're looking at the probe grip, you're looking at sweeping and toggling and translating, healing and towing, rotating, and then a dynamic maneuver. Following it again here, and then turning in long and doing a dynamic. And you can see it sitting over top of the compartment 2 tendon there. This is a question of EPL attritional tear. This patient wasn't able to perform a thumbs up on his right thumb. He had a very irregular Lister's tubercle, and I couldn't really see the EPL with confidence. Not sure. You could see distal to that location that it was echopoor and really thick, and that's at the distal intersection. Comparing with the contralateral, again, you can see quite a difference between the two. Very hyperemic and thickened, heterogeneous, and translating from distal to proximal, very thickened intrasubstance tears. But when you're performing this dynamic maneuver, it's really important because you can see if that tendon is moving in continuity. So it becomes very thin as it crosses Lister's tubercle and then thick again proximally. We call this a high-grade tear. Compartment 4, EDC and EIP. Extensor indicis is not present in everyone. It's about 60% of the population. There's a common sheath for the EDC tendons and a separate sheath for EIP. Our worksheet again. Short axis. This would be your probe placement. Again, thick retinaculum. Don't be fooled. Don't think it's tenosynovitis. When you're new to this, you often think it is, but it's always going to be thick. You're going to correlate it with the patient's symptoms, of course. You can also see a little nerve and an artery deep to compartment 4. That is the posterior interosseous nerve. It's a deep branch of the radial nerve, and also the posterior interosseous artery. That's going to come into play when there's like a large, maybe a ganglion on the dorsal wrist, and that will cause impingement. You can do a dynamic maneuver with the second digit to see the movement of extensor indicis proprius. This one is very mobile. It's at the deep aspect. You can also count the tendons in compartment 4 by doing some dynamic maneuvers, wiggling the 5th finger, the 4th, and the 3rd, and then the 2nd if you're trying to decide on who's who and what's going on. Compartment 5, EDM, again, over the drudge. Normal variant is 2 slips. Things you might think about. Short axis image, there's the probe, again, right over the drudge is compartment 5. You can wiggle, and in this case, you can see that there are 2 slips moving, and this is the one in compartment 4 for D5, and that's compartment 5. Bifid is very common. You can see 2 slips. This case was a 32-year-old female who came to us from sports medicine with the thought that there was a palpable cyst on her dorsal wrist on the ulnar aspect over the carpal bones, and they wanted us to assess the cyst origin and was there any involvement of the tendon. So she could feel it when she moved her 5th finger. She described a month of clicking and catching when she was extending her 5th finger, and you can see something moving right here. She did have 2 slips of her compartment 5 tendon, and you can see the comparison on the other side where her symptomatic side is quite thick and the synovium is thick. My tip here is you may think it's a ganglion until you toggle the probe, because collagen will look black unless you're 90 degrees to it. There was hyperemia in the sheath. And with a dynamic maneuver, so when she was doing that movement of her pinky finger, the 2 slips were rotating on each other. So this was intrasheath subluxation of extensor digiti minimi. On to compartment 6, ECU. It's in the dorsal groove of the ulna. It's a wrist extensor. It inserts on the base of MC5. It does not move the fingers. Again, things you might think about. In short axis, you can see it should be sitting in the groove, but up to 50% of the population, it may be partially subluxated. Often I think that retinaculum is thick, but it's thick in everyone. And if the patient is not symptomatic and is not hyperemic, I'm not going to call it. Dynamic maneuver for ECU is pronation to supination. It may subluxate volar or anterior with supination and or flexion. This one's normal. This one was already partially subluxated even before we started. And this was a case of a hospital worker who was moving a patient and felt pain at her ulnar wrist and ended up being diagnosed with a massive tear of her TFCC and subsheath tear of ECU. This is just an image showing it subluxated out of the groove. And also maybe you might see a flattened groove, which might predispose to subluxation. Also remember there's a little nerve that travels over ECU. That's the dorsocutaneous branch of the ulnar nerve. Sometimes that's involved in pathology. Ligaments, situated deeper than the wrist tendons, the scapholunate ligament. Often we see ganglions, the dorsal radiotriquetral ligament. We look for avulsion. So the dorsal scapholunate ligament is a compact fibrillar structure between the scaphoid and lunate. You can see it in the calipers there. At least that's what it should look like. To find it, you would follow the long bones to that dorsal tubercle, translate ulnar to C4, and then sweep distal to the proximal carpal row. So to the tubercle, over C4, distal, and you should pretty much land right on the scapholunate ligament right there. You can sweep from proximal to distal, looking at it very carefully. And dynamic maneuver, to stress it would be ulnar deviation. One doesn't move at all. Or you can squeeze a ball or make a fist. The idea is going to push the capitate like a wedge through the scapholunate space when that ligament is torn. If the ligament's intact, the joint space won't change in size, and these ones didn't change. This was a 20-year-old female with focal swelling in her dorsal wrist and pain with extension The question was it a ganglion cyst? She said it recently became larger and painful. She had no history of trauma. That's her palpating it. You can see how prominent it is with flexion. Traveling from proximal to distal. As you come over the scapholunate ligament, and it's multiloculated, low-level echoes, distal to the radius, over the carpus, and we thought it was arising from that midcarpal joint. You're going to differentiate it from fluid by just compressing. Ganglia don't compress. Think about that nerve that's located there. This patient had a positive sonographic Tinel sign. So with some pro-pressure there, she had symptoms. If there's hyperemia in the wall, you're going to think it's probably a synovial cyst as opposed to a ganglion. You can see posterior acoustic enhancement and a thick wall. This is an example of scapholunate separation and synovitis hyperemia in the ligament. You can see widening of the joint compared with the contralateral. It's disorganized, it's echo poor compared with the contralateral. And again, you get this feeling that the capitate has pushed through into that proximal row when you sweep over it. To find that dorsal radial triquetral ligament, that's the angle that you should have of your probe. It's a capsular ligament, and usually you'll see changes like synovitis changes deep to compartment 4. How to find it? From the tubercle, you're going to sweep all the way to the distal radius and then rotate that probe towards the triquetral. Use radial deviation to tighten it. You can see it's right here. This is an example of a triquetral avulsion, post-fouche or fall on outstretched hand. You can see the x-ray, and there's a little echogenic fragment there off of the triquetrum. Few cases I want to share with you very quickly. Very commonly, we see these cases on the radial wrist, decurving stenosing tenosynovitis of compartment 1. Patients complain of radial wrist pain with thumb movements. Usually this is where they're going to point. They may come for a question of a ganglion. They often have pain with extension and or abduction, and it's caused by repetitive movements. And they tell you where they have their pain and what movement causes it. Clinical test is Finkelstein's test. Make a fist and deviate. Pain will be on the radial aspect. Often we see this in young moms because they've got little babies or young children and they're lifting them. In this case, EPB is affected and the sheath is thick. This is a disease that begins at the retinaculum. The retinaculum thickens, it clamps down on those tendons, then those tendons have trouble moving deep to it. They get thick, there's less room, and then you get degenerative changes. One or both of the tendons may be involved. May see fluid or debris in the sheath, and you're not going to see it at the retinaculum. You'll see it distal or proximal to the site of compression. You want to always compare with the contralateral, tendons thick, and also the sheath. And again, in long axis, you're looking at the retinaculum. Partial thickness tears might be seen. It's not as common, but sometimes you see them. And dynamic assessments are really important. You want to see if that tendon is jamming up under the retinaculum. In this case, it's not. This was a case of query decurving tenosynovitis, and compartment 1 was normal. So then what? What you want to do is ask the patient to point. In this case, this was the CMC joint that was affected. She had degenerative changes, and that's where her pain was. And I want to remind you that the CMC joint is located deep to compartment 1. This patient came to us for a UCL assessment. He had had a ski injury a year ago and had MRI twice and was diagnosed with a partial tear of his UCL, but he had continued pain. And so it was suggested that maybe the UCL, the joint was lax. So he came to us for assessment of it. And it turned out that the UCL, the joint, the MCP joint, wasn't lax. But what he said was he had this pain in this area, especially with abduction and extension. He did tell us that since his injury, he started taking some rowing lessons, and he also came to us for one of the fingers triggering on his other hand, and he had trigger finger because of repetitive movements. He said he had a snapping at his radial or distal forearm when he performed those movements, kind of in the location, maybe a little bit distal to where he's pointing. So we had a look up in that area, from proximal to distal, following. APL crossed over compartment 2, and you can see as you come distal, the retinaculum is very thick. There's a little tear in it. It was very difficult to follow those tendons in short axis. I kind of felt like one of them was rotated. It was hyperemic at the retinaculum. Compartment 1. And you can see in the retinaculum, there's a little intrasubstance tear, and the tendon is having a very difficult time to travel deep to it with dynamic assessment. At his area of symptoms, when he performed that dynamic maneuver, you can see the tendons of EPB were rotating on each other. So that to me looks like an intersheath subluxation. And to me, I felt like there were 2 slips. So differential is going to be that there's a tear. My point here is talk to your patient and ask them where their pain is. This one was that pulsatile mass. Earlier, you saw it when I talked about palpating. This patient came to us because it was a question of a ganglion at the CMC joint. And what we saw was this structure here at the CMC joint, but it turned out to be a pseudoaneurysm. Quickly, I'm going to talk about the proximal intersection. It's located approximately 3.5 to 4.8 centimeters proximal to Lister's tubercle. It's where C1 crosses over C2. I think of it like a sandwich. You've got white bread on top and white bread on the bottom, and maybe some dark jelly in the middle. So you're looking at this white line, and then the filling in between. This patient came to us because he was having pain at her distal forearm. Often, this proximal intersection syndrome is caused by overuse, repeated flexion and extension, commonly rowing or weightlifting, maybe sweeping a roof for 5 hours or raking leaves for 5 hours or more. That was her history. They have a painful lump, and often there is some crepitus that you can feel or hear during flexion and extension of the wrist. She complained of pain with movement of her thumb, and she said it was shooting up from the base of her thumb and into her forearm. What we saw on ultrasound was echogenic muscle belly here, compartment 1, and this is compartment 2, and was very point tender with pressure from the probe. When you compare with the contralateral, the muscle belly is very thick and echogenic. This is DOMS, delayed onset muscle soreness, and you will look for echogenic appearance without any fiber disruption. That's how you're going to diagnose DOMS. Comparing with contralateral, the normal side is hypoechoic. The painful side is echogenic. And when you look in this area where I call this sandwich, this is the normal side where it's really crisp, these lines. And on the symptomatic side, it becomes thickened and blurred. Often there's some fluid in here. It might be hyperemic. This is an adventitious or frictional bursa that forms, and you may or may not see hyperemia, along with delayed onset muscle soreness. You may or may not see hyperemia. So many people went into creating this talk. My family, my friends, my colleagues, my patients, and Stan the Man, our skeleton. Special thanks go out to my mentors, my MSK radiologists. The Bone Squad team are fabulous, and the MSK fellows, I have so much fun with them. And an extra special thanks to Dr. Laclouis, who's my most important mentor. Thank you. I'm going to stop sharing.
Oh, thank you, Sandy. That was amazing. Masterclass. Fabulous.
Thank you.
We will open it up for questions again. Remember, you're being recorded, so if you don't want to be recorded, please type your question in the chat, or you can just ask away.
I'm okay if there's no questions.
Well, it was really clear. I think
We have
there's
a
some
comment.
comments.
We have a comment from Pablo. He says, great cases and dynamic maneuvers demonstration, Sandy. Your work is really inspiring for those who are MSK ultrasound passionates.
Thanks, friend.
Any other questions or comments? I mean, that was amazingly clear. Like, it's beautiful images, and with the showing the position of the pro is just like unreal. Thank you. And this, like, what a masterclass. I want to thank you for doing this, and thank you for all your contribution, like immense contribution to our program. Really, like a core faculty for us, and teaching all the fellows throughout the years has been amazing, and I think everybody's better for it. Also, teaching the staff, including myself, all sorts of tricks, and I always learn from you. So I'm very grateful you're with us and teaching us. Thank you.
Thank you, Professor. I always learn from you every day.
Yeah, it's mutual. Trust me. Thank you to our alumni who are sponsoring these lectures, and thank you to our donors, as well as everybody who came today or whoever is watching the recording. I will send it back to Karen for announcements.